Let's continue to look at the most unique collection of videotapes of physical findings of neurology that there is in the entire world here at MedQuest. The homonymous hemianopsia means that you lost half hemi of the visual field of each eye. Anopsia, hemi, half, a, without, opsia, vision. Hemianopsia means half the visual field of each eye. Homonymous means it's on the same side. How it's tested to say, I'm losing the left side of the visual field of each eye, or the right side of the visual field of each eye. Half the visual field, hemianopsia, can't be seen, but it's on the same side of each eye. How is this tested? Is to pull the arms in and say, just like right now, can you see me here? Can you see both of my arms? Can you see both of my arms? Can you see both of my arms? You should be able to. That's quite the wingspan, Conrad. So the thing is that both of each side you say, hey, can you see me here? If we were doing homonymous hemianopsia testing, can you see me? Oh, can you see me? Can you see me? Can you see both of them? So you say to people, tell me when you can see my hands moving. See, if you were having homonymous hemianopsia, it'd be like this. Hey, I'm moving my fingers. Can you see them? Can you see them? Can you see them? Now I see them. That's not testing for homonymous hemianopsia. Hi, you can't see my fingers moving, can you? You can't see my fingers moving. Can you see them? Oh, I see it now. I see it now. That's how you test visual fields. Just like what I'm doing with you now. This should be the full normal visual field. Yes, I can see you, I can see you, I can see you. But if you had a homonymous hemianopsia, it would be like you were here. Oh, I can't see, but you don't know that. You think you can see everything. So this would be normal. I can see everything moving. I can see everything moving. This would be an anopsia. My hands are still moving, but you can't see it till it comes closer. And what it means is that you've got a temporal parietal lesion. So homonymous hemianopsia, the patient doesn't say anything because they don't know that they're missing it. The hemianopsia means the person doesn't know they're missing half a visual field. They're just looking at one side of the room. They're looking at one side of the world. And you say, why are you looking over there to the left? I'm not looking at the left, I'm looking at the center. And you look at them and you go, no, you're looking at the left. Hi. You're looking at the left. I'm not looking at the left. I'm not looking at the left. I'm looking at the center. No, what are you talking about? We're over here. We're here. And your eyes are deviating over here. Your eyes are deviating over here. They're not deviating. I'm looking at the center. It's like politics. Everybody thinks that they're looking at the center. No, you're on the left. You're on the right. Nobody sees the other side. So the person doesn't know that they're missing it, but their eyes deviate towards the side of the lesion. If the lesion is on the left of my brain, I can't see the right. If I can't see the right, I look at the left. If the lesion is on the left side of my brain, I can't see the right. I can't see the right, I look towards the left. I can't see the right, I look towards the left. And that's what a homonymous hemianopsia looks like. It's usually a middle cerebral artery infarction where you've lost the optic tract as it goes back to the receptive ophthalmic optic receptive area in the back of the brain. So a homonymous hemianopsia is usually losing the optic radiations and tracts as it's going back to the occipital lobe where you have the receptive epithelium in the posterior part of your brain. So that's where the defect is. It's a stroke of the middle cerebral artery. The test that confirms the diagnosis, well, you have visual field testing and you scan the brain like any other stroke. So homonymous hemianopsia, half of each eye missing in both eyes, the same half in each eye. You look towards the side of the lesion. Stroke in the left, look in the left. Stroke in the right, look at the right.
If we place yellow and red squares in front of the patient, we can see how the yellow image on the left from both eyes passes to the right side of the brain. Conversely, the red image from the right side passes from both eyes to the left side of the brain. The brain puts both of these images into the yellow-red squares.
When I had my stroke, one of the problems I had was I could not see on the left side, and which caused lots of problems. I would run into things. I used to run into the handicap signs. I had trouble walking across the room without falling, and my children's toys, I could not see to walk around them.
Now, that gentleman in the picture did not know that he couldn't see half the visual field. He just thought it was like this. Like you see me and you go, oh, wait a second. Well, you go, what are you talking about? You can see the whole person. No, I can't see the whole person, Conrad. I can't see left-hand side of your body. I can see that part. Really? You're not missing anything. You're not missing anything. What are you talking about? Oh, well, I don't know it because I don't know it. I can't see it. You see, the person with the homonymous hemianopsia would be like you right now. Can you see it? Can you see it? Can you see it? Can you see it? Oh, now I can see it. Yeah, well, Conrad, you can't see the entire right side of the world. What are you talking about? I'm looking at the right side of the world right now. No, you're not. That's the center. That's the right. What's the right? That thing over there. Oh, you just can't see it. Homonymous hemianopsia. It's tested by covering each eye, and the patient closed their eyes, and you're assessing each visual field by confrontation. Confrontation is what I just said this. Tell me when you can see it, tell me when you can see it. That's confrontation. The patient looks straight at the examiner's nose. You're looking right at the center, and you say, tell me when you can see my hands moving. Can you see my fingers moving? Can you see my fingers moving? Now. That's one. And they bring their hand in front of the periphery, and from the periphery, and the patient says he's able to see it. Now you know how you test for this. So if you can see your hand and the patient can't, you got a visual field defect. Now there is more formal visual field testing, but you can't do it at a bedside. You can't do it practically to be able to detect little itty bitty holes in the vision. So this, the step one question is, this is a defect of the optic radiation. That's the neuroanatomy question. The anatomy question is, it's the middle cerebral artery. The pathology question is 80% embolic stroke, 20% hemorrhagic. So the pharmacology question is, aspirin inhibits cyclooxygenase. The pharmacology question is, switch to clopidogrel, inhibiting platelets as well. Oh, the pharmacology question is thrombolytics in the first 3 hours by activating plasmin, So is this an anatomy question, neuroanatomy, optic radiation, optic tracts? Is this a pathology question, embolic 80% of the time from the heart? Is it a physiology question, decreased flow of blood? Is it a biochemistry question? Brain dies in 3 hours because brain tissue has no glycogen. Brain tissue has no glycogen, but muscle does. That's why for hearts you can reperfuse them at 12 hours and brains only for 3 hours, because brains have no glycogen, so therefore neural tissue is based on delivering glucose. Is it an anatomy question, a physiology question, a pharmacology question, pathology question? How do you know? You don't. You don't. Only half the visual field is missing from each of them, and what you see here is that the stroke is the most common cause of that. Embolic 80%, says Mr. Pathology. And the left sided lesion will cause a right visual defect, says stroke on the left, Mr. Neuroanatomy. Scan of the brain shows the abnormality, says Mr. Anatomy. This is an extraordinary summary slide. This shows you where each piece of neuroanatomy in the radiations occurs, and it is fantastic. I know that you're waiting for bitemporal hemianopsia with our chiasm being impaired over there, but where is the defect in this patient? If you were to zap out the whole optic radiation, that's in a homonymous hemianopsia, there. Homonymous hemianopsia, there. The optic radiation. This is the neuroanatomy. Don't you feel good? I do. Same thing happens there if you zap out both parts of the eye. Oh yes, it's fantastic. So these pictures of trying to summarize, that's the one, like what we're doing here. This is where you should really stop and pause and say, hi, over here I've lost an entire eye. Here, I can't see out of my right eye. Over there, it's completely black. The only way to get it completely black is you've got to zap out the optic nerve or the retina. Bitemporal hemianopsia is the optic chiasm. Here, this is a homonymous hemianopsia. This is a homonymous hemianopsia. And the eyes don't see one side, so they look towards the side of the lesion. Fantastic picture, isn't it? You get a stroke here, middle cerebral artery stroke. But our point about this with the physical findings cards is that we're going to be finding these to all the cards and how to tie it together. It says when you're studying, what is the anatomy of this? Is this a ganglion in the brain? It is a ganglion in the brain. Ptosis, why? Because the third cranial nerve lifts the palpebrae superioris, the levator palpebrae superioris, third cranial nerve. The causes can be tumors and cancers and tumors. Ptosis, meiosis, anhidrosis. Here's ptosis, drooping eye and constricted. Ptosis, drooping eye and constricted. Ptosis, drooping eye and constricted. Can you see? Pause and absorb. Now, when you see a Horner syndrome, you see ptosis, meiosis, and anhidrosis, absence of sweating on the forehead of that affected side. These three things here, and what they are, they're from mediastinal tumors. Really, they're affecting the vasonervorum, the blood vessels that is feeding the carotid artery, zapping out the blood vessels on that side so that you damage the cervical sympathetic chain. And that's the answer. Sympathetics lift the eye. Sympathetics dilate the eye. Sympathetics sweating. Remember, sweating, physiology speak, sweating is the only part of the sympathetic nervous system that uses acetylcholine at the postsynaptic. Sweating uses acetylcholine at the sweat glands for the postsynaptic. Horner's syndrome. Next card. Internuclear ophthalmoplegia, INO. An internuclear ophthalmoplegia is one eye does not cross the midline, the other one has nystagmus. We're going to show you several versions of this. This is a lesion of your medial longitudinal fasciculus. This is the most common association with a person who has multiple sclerosis. The lesion is in the median longitudinal fasciculus. One eye doesn't cross the midline, the other one has nystagmus. Let's see it. So now you've seen multiple versions of the internuclear ophthalmoplegia. One eye can't cross the midline, the other one has nystagmus, multiple sclerosis, and scan the MRI. Scan the MRI. One eye can't bring it past the midline towards the center, can't adduct towards the center. The other one has nystagmus, and you look trying, you can't look to the opposite side because you can't go past the midline, and you have nystagmus. Where's the defect? Brain stem. It's multiple sclerosis of your brain stem. Multiple sclerosis means your right eye, the eye that's here with the defect, can't cross the midline because it can't adduct the eye, and the other eye is developing some nystagmus, and it's from multiple sclerosis. And every time you see the word multiple sclerosis, it means MRI is the best initial test, MRI is the most accurate test. MRI is the best initial test, MRI is the most accurate test. Steroids is the initial therapy for anything with acute multiple sclerosis. Etiology is unknown. What causes those plaques in the brain is unknown. We don't know what causes those plaques in the brains. Anybody that says they know is making it up. And all MRIs for neuro, everything except bleeding. Wow, I wish I had this when I was a medical student. I wish I did. All right, neck stiffness. Let's do a super easy one. Neck stiffness is just what the word means. Why do we have to say neck stiffness? Why do we have to say nuchal? What's the difference between neck and nuchal? $38,000 a year worth of tuition. That's what the difference is. Wow. Or $48,000 or $52,000, depending on where you're going. So, nuchal rigidity, neck stiffness, and neck stiffness is meningismus. It goes with photophobia, Kernig's and Brzezinski's. Although I tell you, which one's Kernig's and which one's Brzezinski's, I can still never remember. I can still never remember which is Kernig's and Brzezinski's because it doesn't matter which one it is. They both mean neck stiffness. Both neck rigidity, they're both neck stiffness. Okay, so when you see neck stiffness, this is inflammation of the meninges. The most accurate test is a lumbar puncture. What does meninges mean? Well, it's a $5 word for covering. That's what meninges means. It's a $5 word for covering. For covering. It's the covering of your brain. Want the brain to be protected so that things can't get in there. And although neck stiffness means that you most likely have an infection causing inflammation of that covering, it would be much worse if you didn't have the meninges, much more infection. Knees flexing when you move up the neck thing about Kernig's and Brzezinski's doesn't matter because it means the same thing. It means you have an infection or inflammation of the covering of your brain, infection, meningitis, subarachnoid hemorrhage. Blood is irritating. Blood is inflammatory in the meninges. It causes fever, photophobia, Kernig's, Brzezinski's. You can't distinguish from neck stiffness from meningitis or subarachnoid because they both have the pain fibers. Does brain tissue have pain fibers? Does brain itself have pain fibers? No. Brain itself does not have pain fibers. Interestingly, if you cut the brain, it doesn't hurt. You're saying to me, you mean the brain doesn't have sensory nerve endings? It does not. The covering of the brain, the meninges have the pain fibers, but not the brain itself. So Kernig's and Brzezinski's and photophobia are with both meningitis and subarachnoid hemorrhage. Can you tell which organism there is by the neck stiffness? No. You can't tell what organism. You scan the brain and do a lumbar puncture. Why not an MRI? Because the MRI is not looking for a mass lesion. The MRI would be looking for multiple sclerosis. And you're doing the CT scan because it's better when looking for blood. That's why you're doing a CT scan. Neck stiffness, meningitis, subarachnoid hemorrhage. Blood is irritating. It is. The next thing is this. If you drink blood, does blood drinking cause constipation, or does blood drinking cause diarrhea? Drinking blood causes diarrhea because blood is irritating. All vampires have diarrhea. You feel stuffed up, you feel constipated, not having enough good vegetarian food over there, not enough huevos rancheros with extra bran muffins. Drink blood, it will unplug you. So, next one. This is a very strange word, steppage gait. Steppage. Steppage is that you're having to lift up the leg, lift up the leg, you lift up the leg. Steppage gait. It's usually when you have a peripheral neuropathy. What's seen is just the weird thing. It's like you're stepping, high stepping, high stepping, high stepping, because you got a foot drop. And a neuropathic gait is present when you have peripheral neuropathy, like the peroneal nerve, or which has foot drop. So here we go.
The next gait is going to be that of a neuropathic gait in which the distal lower extremity is affected. For this particular gait, the person has the inability to dorsiflex the foot, and so the foot is actually a foot drop, and the person must step high in order to clear the foot. So if I don't step high enough, I'm going to drag the toe of the shoe, and so what happens is the person steps high to be able to clear the foot. As the foot drags, or as the foot drop position.
He will now act out all the diseases. It's amazing how many neurological defects that same one man has, isn't it? So the neuropathic or steppage gait is from an inability to dorsiflect. Dorsiflect means bringing the toes back to your nose, bringing the toes back to your nose, bringing the toes back to your nose. That's the, okay, dorsiflexion, okay? Okay, steppage gait, okay? The toes back to your nose. Okay, so from the inability to dorsiflect the foot, you can't pull back towards you. So the thighs are lifted extra high because the foot would otherwise get trapped in the rug. So you literally have to bring the high foot up to clear things, or people end up tripping and falling on themselves and breaking their hip. So things like lower extremity neuropathy, because lower extremity neuropathy makes it so that your toes will hit the ground, because the same way the radial nerve has wrist drop, the peroneal nerve has foot drop. So the gait gives this weird appearance where you have to look like you're stepping up on stairs. Big one. Eins, zwei, drei, vier. Who's going to buy the beer? Okay, and you're unable to walk on your heels because you can't lift up your toes. So peroneal nerve is behind your knees. The peroneal nerve is down below behind the knees. That's where the peroneal nerve is, down there. Okay, high boots sometimes. It used to be when women gave birth in stirrups, and you used to put them up in stirrups, and the stirrups would hit behind their knee, and they'd wake up out of giving the birth, and they'd say, here's your baby, get up and walk, and you couldn't walk because the stirrups would hit the lady behind the knees and damage the peroneal nerve. Foot drop. That's the neuroanatomy. Now, it was bilateral lower motor neuron disease. Oh, what is that? Bilateral lower motor neuron. Charcot-Marie tooth. Charcot-Marie-Tooth syndrome. Oh, vasculitis, polyarteritis nodosa. Wedgie, have you had a wedgie? You mean Wegener's granulomatosis? Churg-Strauss, Wegener's polyarteritis nodosa. Vasculitis, 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 damaging the blood vessels around the nerve. And when you're damaging the blood vessels around the nerves get starved off. And when the nerves get starved off, the big nerves drop. So, lower extremity disease or cauda equina. Cauda equina is down at the base of the spine, where the spinal nerve roots come out like a horse's tail. The base of the cord, where the nerves come out like a horse's tail. And that also gives bowel and bladder, and bowel and bladder, and bowel and bladder, and cauda equina. And it's also like on your booty. It's like you have like where you're sitting, like a bicycle seat gets damaged. Polio, not in the United States. Polio is only left to a couple of countries, a few countries. Polio is only left to a few. Polio is only left to a few countries, and none of them are in the United States. So that's it. 4-foot drop, steppage gait. It's peripheral neuropathy, which could be from vasculitis like Wegener's and polyarteritis nodosa, and it's from the vasonervorum being damaged. Now, how is nystagmus? Nystagmus assessed. What causes that rapid beat of nystagmus? Let's see some nystagmus.
Left, right, left, right, left, right.
Beat, 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 beat. And remember, nystagmus has a fast component and a slow component, and nystagmus is always named for its fast component. It's a sudden movement back and forth of the eye. A little bit of nystagmus, 2 or 3 beats is normal. And one movement in one direction is quicker than the other. So you name the nystagmus for its fast component. And nystagmus that's only 1 or 2 beats is normal. Nystagmus can be a sign of phenytoin toxicity and drug toxicity. Nystagmus can be a sign of inner ear things. Benign positional vertigo does it. Perilymph fistula does it. Vestibulitis, Meniere's. Labyrinthitis, vestibulitis, Meniere's. Labyrinthitis, vestibulitis, Meniere's. Perilymph fistula. Anything that's affecting the inner ear or cerebellum cause nystagmus. Inner ear or cerebellum. A few beats is normal one way or the other. However, if it continues, labyrinthitis, vestibulitis, cerebellar problems. Nystagmus can happen at any defect of the labyrinthitis, cerebellum, or brainstem strokes. Labyrinthitis, cerebellum, or brainstem strokes. The 8th cranial nerve, acoustic neuroma, Meniere's disease. 8th cranial nerve in the inner ear, middle ear, inner ear, 8th cranial nerve, Meniere's disease. Labyrinthine nystagmus is like those who are having labyrinthitis. It's associated also with hearing loss and tinnitus, meaning strokes in the brain, in the cerebellum. When you have cerebellar defects, cerebellar defects don't give hearing loss and they don't give tinnitus. When you have cerebellar defects, you don't have hearing loss and you don't have tinnitus. With cerebellar defects and tinnitus. Central nystagmus, like stroke and MS, cerebellar defects don't give hearing loss and tinnitus. If it's in the inner ear, you can have hearing loss and tinnitus. It's kind of interesting, actually, is that you can't stroke out your hearing. You can stroke out speech, but you can't stroke out your hearing. You can't stroke out your hearing. And that's why it is that when you have a stroke, you can get nystagmus and nausea and vomiting and a sense of vertigo when you have multiple sclerosis or stroke or phenytoin toxicity, but you can't have hearing loss and that tinnitus. Hearing loss and tinnitus are in the inner ear, labyrinthitis. They're in the 8th cranial nerve. Now, vertical nystagmus, all nystagmus gives vertigo, because if you think the world is spinning around, your eyes are trying to catch up. If you think the world is spinning around, your eyes are trying to catch up. If you think the world is spinning around, your eyes are trying to catch up all the time. So vertigo and nystagmus go together. Vertigo and nystagmus always go together. How do you tell if it's in the ear or in the brain? Hearing loss and tinnitus. Vertical, meaning up and down, nystagmus, is very rare. Up and down nystagmus, like dunk, 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 dunk. Up and down nystagmus, what do I see? Phenytoin toxicity is drawing into me. My level must be very high, cause I'm vying. Where is my level? Oh, it must be very high. Yes, vertical nystagmus, dinky doink. Where's the level? There's the level. Vertical nystagmus, phenytoin toxicity at high levels. So, the normal, okay, let's take a look. This is an oculocephalic reflex. Let's just see what this is. Hold on, let's see. Ooh, funny faces. So this test, oculocephalic reflex, what is done here? This oculocephalic reflex
keep looking at my nose. Look at my nose, okay? Especially on this one, okay? Look right at my nose. Okay. Look at my nose. Look at my nose.
See, a normal person should be able to focus on a point. Like me looking at this camera. Well, I'm looking at a camera, but what I'm really doing is looking at you when you're studying. Okay? I'm really looking at you. Smelling you too. What I'm doing is looking at you when you're studying. And if I turn my head, see how my eyes are focused on you? That's normal. That's normal. That's normal. You see, no matter which way I'm looking, see, I'm looking at you, right? No matter which way, whichever way I drive, I come back to the place you are. In your eyes, I am complete. In your eyes, I see the doorways to 1,000 churches. I see the resolution to all the fruitless searches. But whichever way I turn, I come back to the place you are. See, poetically speaking, that's true. And also, when you have a normal person, no matter which way you turn them, they should stay with their eyes focused. But a doll's eyes, like eyes glued in the head, that's abnormal. This is the abnormal oculocephalic. The abnormal oculocephalic goes like this. Okay. So that's where the abnormal oculocephalic is. The abnormal oculocephalic is when you turn the person and their eyes don't stay on focus. Okay? They turn the person and their eyes don't stay on focus. That's the abnormal oculocephalic. A normal should stay focused. So this is a brainstem reflex, and it's one of the many ways to tell you, are you brain dead? Oculocephalic reflex is tested by moving the patient's head from side to side. A normal person should focus. Abnormal person, it's like their eyes are glued in their head. You see, these terms, doll's eyes, is not a great test, not a great name, I should say, because which one's positive? You should say oculocephalic reflex intact. I'm focusing, I'm intact. Not intact. It's like a doll's eyes glues in his head. It's like Babinski. Don't say, I don't know what that means, Babinski intact. Babinski, okay, it's better to say extensor plantar reflexes, abnormal. Flexor plantar reflexes, normal. This is a test to see if the brainstem is intact, because you should be intact to be able to say that even if you're sleeping, and if I move your head from side to side, you should stay focused on a point. When it's staying intact and the head is moved the opposite side, they should stay intact. And if the head is rolled and the eyes deviate, okay? So that's the issue. Ooh, look, I've got such a good brainstem, don't you think? I'm staying focused, I'm staying focused, I'm staying focused, I'm staying focused. Not everybody thinks I am, but I am staying focused. All right. So an abnormal reflex is called the doll's eyes. Doll's eyes are abnormal. And instead of the eyes moving in the head, they stay fixed in the skull with no change in gaze. That's what cadavers do. Cadavers. So you could do that with somebody if you're trying to see if they're pretending to be dead or not. A normal person should stay focused. Our next one. So it's a 70-year-old man with stooped posture, difficulty initiating his gait. He shuffles, he picks up speed, turns, stopping. His turns are done en bloc, no turning of the head or trunk. There's a tremor and some postural instability. What does this guy have?
This gait is the gait that is a hypokinetic gait. The prototype is Parkinson's or Parkinsonian type of gait, in which the patient will have a posture in which he'll be stooped over, leaning forward, and then will have difficulty as far as initiating gait. When the gait is initiated, there are small steps. Oftentimes there's a tremor associated with this. And as the gait progresses, there may be a picking up of speed, or what's called a fenestrated gait. And then in turning, instead of having the normal turning, the patient will turn en bloc, which means they'll turn almost as a statue moving around. And then, again, having difficulty starting in the marche petit pas.
What it look like to you, man? You know, there's no diagnostic test for Parkinson's disease. The shuffling gait picks up speeds. That's called festinating gait. Festinating gait. What's the treatment? Levodopa, carbidopa when it's really bad. Levodopa, carbidopa when it's really bad. Ropinirole, pramipexole, which are direct-acting dopamine agonists. When you have a real problem with gait, when you can't move with gait, you can't just use some amantadine. Amantadine squeezes some more dopamine out of your substantia nigra. Now, if you sell these with physical findings flashcards and the basic science of physical findings, yes, you might say, well, why are you throwing in all this extra pharmacology? Because it's not extra. We just want you to get the maximum value out of it. Remember, once you get to the point where you can't move like the guy can't move, it's too far advanced for amantadine. What's this dude got?
So more significantly affected gait. They all have idiopathic Parkinson's disease. This first patient is probably the most affected. His stride length and arm swing are very decreased. There you can see this turning en bloc. He also had some slight freezing in that turn. The amount that his stride length is shortened.
Wow, those guys, they're slow to start. But once they get moving, then they can't stop themselves. Festinating gait. And the treatment for severe Parkinson's, levodopa, carbidopa. A little bit more mild, dopamine agonists, ropinirole, pramipexole. Ropinirole and pramipexole are dopamine agonists. So that's the management. That's the festinating slow gait because it's postural instability. And this is like cogwheel rigidity of your central nervous system on the gait. Now remember, you don't like the tremor of Parkinson's, but for the person with Parkinson's, the patient with Parkinson's, what brings them to the doctor is the gait disorder. They don't like that they can't walk and can't move. That's the main thing that brings them to the doctor. It's a gait disorder. You know what it's like? Here, we're large, we're turbulent, and we're alive, and we're moving fast. But what about all those people that don't have our benefits? So stop complaining about how much you have to learn. Get in there and remember that you have a duty to find out what everybody's like. What is it like, man? You have to try and cross the street, and the light turns yellow. You don't have enough time to move. Wow, terrible. Ugh. Next card. Pronator drift. Pronator drift. So, what is this? What is this gait? What is this pronator drift? The most common wrong answer is confusing pronator drift with a Romberg. The most common wrong answer is confusing a pronator drift with a Romberg. The most common thing is confusing a pronator drift with a Romberg. And we often confuse it with a Romberg because the eyes are closed. And a Romberg, which is a sign of cerebellar disorder in posterior column, cerebellar and posterior column, see, I don't have a positive Romberg because I can stay upright with my eyes closed. I can stay upright with my eyes closed. Sometimes I can stay erect with my eyes closed. But pronator drift is the eyes closed because if somebody sees their hand moving, if you had your eyes open, you'd be like, what are you doing? Get back there. Pronator drift, we keep our eyes closed because if somebody saw it happening, they would correct it on the visuals. Pronator drift.
Hold them up like that if you can, and close your eyes and hold still. Okay. Open up your eyes.
So when you see this pronator drift assessed, you put the arms there and it flips over. So the palms, which are stronger, supinators or pronators? Pronators are stronger, and put the hand down. Supinators, you know it's supinator because you say, hey, give me some soup, here's the soup. An abnormal test flips over. Now which is stronger, pronators or supinators? Pronators are stronger. A normal person, when there's enough for everyone, should be able to have no one dominant group. The supinator, the pronator, supinator, one should not dominate the other. But supination is naturally weaker, so when there's a disease, you will pronate because when there's deprivation, scarcity, the strong group dominates. You close your eyes because if the person saw their hand turning over, hey, what are you doing? Get back to where it belongs. So you've got to keep the eyes open so that you don't, you got to keep the eyes closed so you're not seeing the hand turn and then you force it back. Pronator drift is subtle motor weakness. How subjective is it to say, squeeze my hand, squeeze my hand, squeeze my hand? You don't know whether somebody's having a bad day. You don't know if there's really weak. So squeeze my hand is terribly inexact. See, a normal person should be able to keep the hand supinated. And if you have weakness, you won't. One group dominates. The pronators dominate. Now, which is stronger, extensors or flexors? Extensors are stronger. Most people get that wrong. And as a matter of fact, everybody who's not watching me is going to get that wrong. It's just you're wrong, but you're going to find out about it now. Flexors are weaker than extensors. That's why when we seize like this, extending. The Romberg sign is a sign of posterior column defects. It's a spinal cord evaluation. What part of the neurological system? The spinal cord. And the most likely cause is B12 or syphilis. Now, Romberg is assessed. You keep your feet together and you say, can you stay upright? A normal person should be able to stay upright. An abnormal person will wobble and fall over. A normal person should stay upright. An abnormal person falls over on one side when they close their eyes. So, a Romberg is testing the evaluation of the dorsal columns, the posterior columns of the spinal cord. And the posterior columns transmit proprioception, position, and vibration. The position of your vibrator up the dorsal column. And so when you don't have a dorsal column to transmit stuff up to your cerebellum, you're dependent upon visual cues to your cerebellum. Other than that, you would fall over. When the eyes are closed, you lose these visual cues and the patient falls over. And this is an easy one because this is like one of those classic medical school things where they tell you about position and vibratory and B12 deficiency and neurosyphilis. This is not a hard one. It's in here for completion's point of view, but most people get this one right. This is not the hard one. But isn't it great that we have the chance to be able to have all these things here together? Whitman says, I am larger and better than I thought. I did not know that I held so much goodness. See you in the next section.